Good evening, all. Welcome to this session on reading images. In today's presentation, I will be talking on the interpretation of CT and MRI scans. So, in the initial few minutes, I will be discussing on how to read a CT and MRI scan. Followed by it, I will discuss on some of the films based on the clinical scenarios. So, how to read a scan? So the first thing what you need to look into a scan is the patient details. In the right corner of the image, you have the name of the patient, the date and time, the date of birth and the age of the patient, the date and time on which the scan was taken will be recorded. So once you confirm the patient details, look for the laterality, so which is the right and left of the image. So in a film plate, the left side of the plate will represent the right image and the right side of the film will represent the left image. So therefore, in this film, this is the right eye and right orbit, and this is the left eye and left orbit. And after this, you need to know about the tissue window. For this, you need to understand the window width and window level, which I will not be discussing here. But in short, in an orbital CT scan, we have a bone window and a soft tissue window. So in these two images, this is the bone window and this is the soft tissue window. So how to differentiate between the two? When you see this image, the details of the bone are clearer. So you can see the cortical bone and the marrow. But whereas the details of the soft tissue, soft tissue is effaced. So in this image, the details of the soft tissue is better than the details of the bone. So this is a soft tissue window and this is a bone window. This is how you differentiate it. Why do we need a bone and a soft tissue window? It's because whenever you're dealing with a lesion of the bone, like fracture or a lesion involving the bone or a lytic lesion, you need to look into the bone window. And when you're dealing with the soft tissue lesions, you should look in for the soft tissue window. Once you're done with the window, you should look for whether the film is a contrast or a non-contrast film. So what does this contrast do? It prevents the transmission of X-rays to it. So therefore, the tissues will appear brighter, or in other words, it will enhance with the contrast. The tissues which has rich blood supply or a vascular supply will allow the higher flow of contrast to it, so it will appear brighter. So this helps in identifying the type of the lesion, the nature of the lesion, whether it is a vascular lesion or a lesion which has a rich blood supply. And when you're talking about a contrast, you should always say whether there is a homogeneous or a heterogeneous enhancement, whether there is a low, moderate, or intense enhancement. So how to identify this contrast images? You need to look into three structures. One is the scleral cord, the other is the extraocular muscle, and then the brain parenchyma. If these three tissues are enhanced, then it is a contrast film. So you should always look into these three structures. When you see in this image, the sclera and the muscle and the gray matter, that is the brain tissue, is grayish. But whereas here it is bright. So this is a contrast film and this is a non-contrast. So once you have identified the films with the contrast and non-contrast, move on to the image plane. Identify whether it is an axial, coronal, or sagittal section. So 5 important things. Confirm the patient details. Look for the laterality, which eye or orbit is involved. Then identify the tissue window. Then look for the contrast or non-contrast and identify the plane of the image. And then move to read the details of the orbit and orbital contents. And here now document the walls of the orbit, the orbital apex, adjacent sinuses, and the orbital contents like the globe, extraocular muscles, and the optic nerve has to be looked into. And once you have identified any lesion within the orbit, this has to be described in terms of its location, where exactly in which quadrant of the orbit it is located, whether it is intraconal or extraconal, the size of the lesion, the borders, whether it is regular, irregular, or it is infiltrating, um, and also the internal consistency, whether it is a homogeneous or heterogeneous, the density of the lesion to be compared with extraocular muscles, whether it is iso, hypo, or hyperintense, related to the in relation to the extraocular muscle has to be described, and also the adjacent structures, whether the lesion is producing any mass effect on the globe, or if it is infiltrating the optic nerve or pushing the optic nerve, or if there is any bony changes like erosions or remodeling has to be documented. So how does an image look in a CT scan? As you all know, in a CT scan, X-rays are used, and as these pass through the tissues, they get absorbed or weakened. This is called as attenuation of X-rays, and this is measured in terms of Hounsfield units. Bone being denser, it prevents the transmission, or it doesn't allow the transmission of X-rays, so therefore it appears bright or hyperdense. But whereas the air being less denser, it transmits most of the X-rays to it, and therefore it appears dark. So in our orbital CT, we have a set of Hounsfield values. Anything which is less than water, that is fat and air, will appear dark. And calcification, cortical bone, the metallic foreign body will appear bright. You can see that. The rest of the tissues, depending on their attenuating capacity, will appear in different shades of gray. So here, the orbital fat and the air and the paranasal sinuses appear dark, that is hypodense, whereas the bone is bright, hyperdense. The rest of the tissues, depending on their Hounsfield values, will represent in different shades of gray. A little more about the imaging plane. What is this axial scan? There's something called a Reed's line, which passes through the inferior orbital wall to the acoustic meatus, and any plane which is parallel to it is the axial scan, and any plane which is perpendicular to it is the coronal scan. And the plane which is parallel to the long axis of the inferior rectus muscle is the sagittal plane. And again, we have in the axial, lower, mid, and upper, and the coronal, anterior, mid, and posterior coronal sections. So, the axial scans. The axial scans are taken from lower, inferior to upper. So, therefore, in the initial scans, you will see the prominence of the nose and the maxillary sinus. And as you advance further higher up, you will see more and more of the brain tissue coming in, and the prominence of the nose disappears. So quickly, the structures to be seen in different sections. In lower axial scan, you will see the prominence of nasal bone, and then the nasolacrimal duct, and the inferior orbital wall, inferior orbital soft tissues, and the inferior rectus muscle. And adjacent to it is the ethmoidal sinus and the sphenoid sinus. And then you have the inferior orbital fissure. And in the mid-axial scan, you will see the maximum circumference of the globe, the lens, and then the entire length of the optic nerve, the extraocular muscles lining the adjacent wall. And here there is an optic canal, and this is the superior orbital fissure. Adjacent to it is the ethmoid sinus, posterior to it is the sphenoid sinus. Further higher up, you will see the superior part of the globe, lacrimal gland, superior ophthalmic vein, then the frontal sinus, and then the superior orbital soft tissues with the rectus muscle, and this is the trochlea. So coronal scans, again coronal scans are taken from anterior to posterior. So in the initial anterior scans, you will not see the prominence of the, you will not appreciate the lateral and the inferior wall. And it comes into picture only from somewhere around mid coronal. And quickly into the structures. In the anterior coronal, you will see the anterior orbital soft tissues, the palpable part of the lacrimal gland, and the frontal sinus. And in the mid coronal, you will see the equator of the globe and surrounded by the extraocular muscles. And here you will see a part of the lacrimal gland and the lacrimal gland fossa. And then you will see a superior ophthalmic vein, superior ophthalmic vein, and this is the superior or orbicularis, superior orbicularis, superior oblique muscle, superior oblique, and then you will see adjacent to it the ethmoid sinus, and below you will see the maxillary sinus. And in the posterior coronal, the globe disappears from the view, and you only see the four extraocular muscles and the optic nerve. And here you will see the inferior orbital fissure, adjacent to it maxillary sinus, the ethmoid sinus. And at the level of the orbital apex, you will see the optic canal, superior orbital fissure, the inferior orbital fissure, which opens into the infratemporal fossa. Here you will see the ethmoid sinus and then the sphenoid sinus. So we'll move on to interpretation of MRI scan. So most of the parameters what we saw in a CT scan holds good even here in MRI scan, except for the tissue window. We don't have a tissue window in MRI scan, but instead we have sequences. We have a T1, T2, fat suppressed, flare, stare, and ADC. But we will be concentrating on T1, T2, and fat suppressed sequences. I will not discuss about the physics behind the relaxation, that's the T1 and T2 sequence. But in short, we all know that in electromagnetic, in a MRI, electromagnetic field is a magnetic field is created, and a radio frequency impulse belonging to electromagnetic radiation uh, is used. So therefore, when tissues are subjected to this strong electromagnetic field, and which through which the radio frequency impulse passes, the protons in the tissues gets excited and they reach a level of higher excitation. And then once the radio frequency impulse is cut off, the protons which were in the higher excited state will come back to its lower excitation state. So this stage of transition, that is from high energy to the low energy state, in other words, the protons which were in the higher excited state will relax back to the lower excitation, that is lower energy levels. During this phase, whatever the events occur will be documented as T1 and T2 weighted. The first relaxation which occurs is the T2 relaxation. So here I already mentioned the protons which are subjected to a magnetic field and a radio frequency impulse will remain in a higher excited state. In tissues like water, CSF, vitreous, edema has a higher amount or excessive amount of free protons, and these free protons will remain in an excited state for a long time, and it will take a longer time for it to relax back to its resting state. So during this time, when the energy is recorded, you will find that the vitreous, CSF, edema will appear bright because it has higher proton. It is taking a long time for it to relax back to its resting state. So this will produce a bright signal. So when T2 weighted image, the tissues which has higher water content like aqueous, vitreous, CSF, and some stages of hemorrhage and edema will appear bright. But whereas fat will contain protons, compact protons, and they relax back to their resting state very rapidly. So therefore, they appear somewhat grayish. This is in T2. And the other relaxation, which is T1, occurs when the second impulse of the radio frequency waves passes through these excited protons. So now the protons are protons in the fluid component, that is in the CSF and water, are already in the excited state. So when a second impulse falls on it, they fail to produce adequate transverse magnetization. So therefore, they appear dark. Whereas the fat is already in a relaxed state, when a new radio frequency impulse passes through it, they acquire the higher energy state and they they are represented as a bright signal. So in a T1 weighted image, the fat appears brighter or hyper intense, but whereas the fluid components like the vitreous, aqueous, CSF, and other edema and some forms of hemorrhage will appear gray or dark. So again, in T1 weighted images, fat appears bright and the fluid component CSF, vitreous, aqueous will appear dark. But whereas in T2, the CSF, vitreous and hemorrhage, edema will appear bright, but whereas fat will appear gray. So I've already described most of the things. So this is a T1 weighted because the vitreous is gray, and you have the um, uh, fat here which is bright. And here you're seeing the cortical bone. Even the cortical bone has lesser proton contents, therefore it doesn't produce any signals. So it appears black. It is a white signal. It appears black. But whereas a marrow in it will appear gray. Then you have the extraocular muscle, which is gray, and in the middle you have the optic nerve. The signal in the optic nerve will be similar to that of the brain matter, brain parenchyma. And here you have the ethmoid sinus, and posterior to it is the sphenoid sinus. This is a T2 weighted image because the vitreous is hyperintense. And one important thing, the tumors, most of the tumors in an MRI will appear hypointense, and in T1 weighted, and in T2 weighted it will appear hyperintense. So let's move on to some of the clinical scenarios. So here we'll read the CT image in a stepwise manner. So this is a CT scan orbit, axial section, and the window. This is a soft tissue window with uh, the contrast. You can see the sclera enhancing. So this is a contrast image. So this is a orbital CT, axial section, soft tissue window, contrast image showing a well-defined lesion in the intracorneal compartment of the left eye, which is enhancing with the contrast. So similar lesion when you look here in the coronal section. So again, this is a CT scan orbit, coronal section, in the mid-coronal section, um, soft tissue window with a contrast image showing a well-defined lesion in the intracorneal because surrounded by the extraocular muscles, adjacent to the optic nerve here, shows a well-defined lesion within the intracorneal compartment, which is enhancing with the contrast. So it's an intracorneal lesion which is enhancing with the contrast. So look at the clinical picture. He is a middle-aged man with a mild axial proptosis, showing a mild proptosis and then not involving the vision. Pupil is normal with the full extraocular movement. And this shows that the clinical and the radiological findings, when you compare it, it shows that it must be an axial vascular, intracorneal vascular lesion. Most probably it is a cavernous hemangioma. And then the next situation, here you are seeing she's a 35-year-old female. She's showing a fullness in the superolateral orbit. And there is a palpable mass here with the inferior dystopia, and there is drop in the vision, and the symptoms are ranging from somewhere around 4 to 6 months. So when you see the clinical image, radiological image, I'll read it. So this is a CT scan orbit. Again, this is the mid-coronal section, and this is a soft tissue window, contrast image, sclera taking up the contrast, showing an ill-defined heterogeneous lesion which is extending up to the mid-orbit in the superolateral superolateral orbit quadrant of the right orbit, which is enhancing with the contrast. And when you see, which is heterogeneous enhancement. And when you see here in the axial section, this lesion is irregular, ill-defined, and extending up to the orbital apex. So looking at the clinical and the radiological features, this and you can even see here, important, this is very important. You're seeing a erosion in the bone. So this lesion is irregular and it's creating a bony defect. So this appears something like a malignant. and in the lacrimal gland area. So this is a malignant, it's likely to be a malignant lacrimal gland tumor. And then let's move on to the next scenario. This is a acute history. This is a middle-aged man presenting with pain in the right eye from past 15 days, not involving the vision or pupil. And when you see here, there is mild limitation of abduction. The CT scan shows, again, this is a CT scan orbit axial section, and this is a soft tissue window contrast image showing thickening of the extraocular, that's a lateral rectus muscle, involving the muscle belly as well as the insertion, and the margins are irregular. And when you see in the other sections, when you see in this film, coronal section, you're seeing infiltrations into surrounding soft tissues, whereas the orbital fat plane is clear. So this is more likely to be a orbital inflammation, myositis. Next, elderly patient with a known case of thyroid disease, presenting with acute proptosis with swelling and chemosis. And when you look at the CT scan, this is again a CT scan orbit axial section, a soft tissue window, contrast image showing a proptosis in both eye. And there is thickening, fusiform thickening of the extraocular muscle, sparing the tendon. And the orbital fat plane is also clear. And this is a TRO. This is a thyroid related orbital. And again here, this is a history of trauma showing edema in the upper and lower eyelid with limitation of elevation. So when you compare this, so here you have a axial scan, CT scan orbit, axial section. This is a bone window. You're seeing the details of bone, and it's a non-contrast because sclera is not enhanced, and showing a hypodensity in the adnexial region of the left, in the left adnexia, along with discontinuity in the medial wall of the left orbit, and you're seeing the normal muscle content. And also, when you see here in the coronal, posterior coronal, again you're seeing the discontinuity and the normal contour of the muscle. So this is a case of medial broad fracture without muscle entrapment with orbital emphysema. Let's move on to read some of the MRI images. So again here, so this is a MRI scan, axial section, and what sequence? This is a T1 sequence because vitreous is dark or a hypointense, whereas fat is bright. Fat is bright. And when you're seeing the extraocular muscles, they are grayish. So it is a non-contrast. So this is the axial scan, MRI orbit, axial scan, T1 sequence, non-contrast image showing a well-defined iso-intense lesion. You're comparing it with the extraocular muscles. Iso-intense lesion within the intracorneal space. Same lesion in a T2 image showing hyperintensity, and in a contrast. See, this is a contrast image where the muscles are taking up the contrast, but whereas the fat details are not clear, are not seen. So this is a fat suppressed. So this is a T1 weighted fat suppressed contrast image axial section showing a well-defined mass in the intracorneal space, which is enhancing, progressively enhancing the contrast, showing more likely to be a intracorneal vascular lesion. So cavernous hemangioma. Then the other image. So here again this is a MRI orbit T1 weighted image because vitreous is black and orbital fat is bright, bright, and showing a well-defined lesion in the intracorneal space involving the optic nerve. And when you compare the same lesion, there is a non-contrast film. When you compare it with the contrast images, you can see the extraocular muscles taking up the contrast. There's a contrast film, but fat details is not seen. So there's a fat suppressed. But even weighted fat suppressed contrast image showing a well-defined intracorneal lesion involving the optic nerve, which is enhancing with the contrast. It's more likely to be a glioma. The next image. So this is a MRI scan of the orbit, posterior coronal, showing a posterior coronal T1 weighted because fat is bright, non-contrast. The extraocular muscles are grayish, showing a well-defined lesion which is isointense to the extraocular muscles in the intracorneal space, and the same lesion with a contrast. It is a contrast, but this is a fat surface. The fat details are not seen. So this is a T1 weighted because here you can see the CSF. CSF is not bright. So this is CSF is dark. Therefore, this is a T1 weighted um, fat suppressed contrast image showing a well heterogeneous lesion in the intracorneal, well defined heterogeneous lesion in the intracorneal compartment, and when you, which is moderately enhancing with the contrast. When you see here this lesion, there is contains something like a black a spot in the center. This is the optic nerve. This is a normal optic nerve. The lesion is surrounding the optic nerve. This is likely to be a meningioma. So another image of meningioma. So this is a axial scan, MRI scan, axial section, contrast. Stocular muscle is taking the contrast. Contrast, fat suppressed, showing a contrast enhancing lesion in the intracorneal space surrounding the optic nerve in the right orbit, which is more likely to be a meningioma. And this is a typical railroad or a tram track site. And then the other example here again is a thyroid. So there's a T1, this axial MRI orbit axial scan T1 weighted image showing a on contrast image showing thickening of the extraocular muscles. There is fusiform enlargement of the extraocular muscles bearing the tendon, and this is more likely to be a thyroid. When you see the posterior cornea, you can see the enlargement of the muscles. So this is thyroid orbitopathy. So thank you.